Good morning, everyone. Today is Wednesday, May 18th, and we are coming off of a very high energy of yesterday's conference first day. As a quick conference recap, we heard from our FSSA and DMHA leaders, Dr. Brianka Merritt, Dr. Carrie Corey, and also Rachel Johnson-Yates on the strategic alignment initiatives within both SSA and DMHA. There was a call to action to really soak in the information, take notes, identify where you want to be in 6 months, and then also looking at really the direct impact that you are having on your organization from the perspective of the learnings of yesterday's individual accountability track. Dr. Dennis Rednick gave us an excellent primer on what exactly individual accountability is, where he looked at responsibility being the intent and accountability being the result. We also heard from Ms. Jody Ann Berry speaking from her shared experience as activator, speaker, leader, influencer, public health expert, and of course, foremost, a wonderful public relations support of diversity, equity, inclusion, and all of the wonderful cultural competency components of that within our organizations. In the afternoon, we started our specific sessions from our speaker applications that were awarded to be part of the conference. And we heard from the Dr. Gabe Vayas of the Los Angeles School of Mentorship regarding the importance of mentoring and having those direct, intimate relationships, not only on professional development and career, but also on just human-to-human relationships and having that balance and checkpoint with another individual prior to driving change management. And we rounded out the afternoon with an excellent overview of truly a technical assistance center from the Hands and Autism team from Dr. Naomi Sweezy and also Dr. Tiffany Neal. An excellent day one, of which recordings will be available in 2 weeks, and also the presentations from yesterday are available for download on the Networking Cafe. This day today, we are going to be focusing on the track of organizational adaptability. Organizational adaptability will evolve us from our individual specific learnings on individual accountability and move us towards what does change management at our employer organizations and our environmental impact with our community outreach stakeholders and partners, our patients, families, and their caregivers. What does that look like in composite when we're looking at organizational change, systems level change, and the overall interdependencies and complexities of how that change needs to be both specific and collaborative and interdependent at the same time. So this morning, in order to start us off on what is organizational adaptability, I'm going to take just a few minutes to define what organizational adaptability is, and then I'm going to invite a panel of subject matter experts, true stalwarts in their field, to really showcase to us in a panel conversation the interaction of the different perspectives that have to be aligned really simultaneously and congruently in order to support effective change management and an organization's continuous ability to adapt. So as we begin, I'm going to change the slide over to give you what should be a very familiar slide formation for those that have participated in the previous webinars and also in our Transformation Change Agency team. And that's our Cultural Competency Enhancement Project overall framework. So every time we introduce a new topic, we talk about really the framework, its history, any policies that have been enacted to support that framework, its disciplines, and ultimately a call to action. So we've modeled that today with our organizational adaptability framework. So what is organizational adaptability? It is a framework, and the framework is based off organizational adaptation theory, of which this theory is defined as intentional decision-making undertaken by organizational members leading to observable actions that aim to reduce the distance between an organization and its economic and institutional environments. Intentional decision-making. In our strategic alignment discussion yesterday with FSSA and DMHA leadership, there was clear intent and clear specifics in the guiding principles of both the DMHA mission and then aligned with the FSSA mission. So that intentional decision-making has a path forward, it has a direction, and it is undertaken by organizational members. So we, wherever we are, wherever we lead from, as individuals, as management, as overall strategists, as day-to-day doers, that overall change, that adaptation starts with us first. We have to choose to begin. Leading to observable actions, it's that evidence, the evidence point that Ms. Jody Ann Burry spoke to, that Dr. Carey and Rachel identified. When Rachel identified and said it has to be driven by data, and when Dr. Carey identified that it must be looked at and measured through vehicles of grant funding and other opportunities to support compensating that change and using dollars to initiate that change. To reduce the distance between an organization and its economic and institutional environments. That's a lot. The distance between an organization can be as specific and felt daily as the incongruency between an organization's policies, its expectations of its staff, and how it's actually executed, through to as wide of complexity of models as the impact of community change, external factors like COVID, and the continuous pressure upon our mental health and addictions providers' overall resources and the network that has to be maintained in order to support the safety measures for mental well-being across our state. Institutional environments also speak to what's happening at the federal level, what's happening on the state level, and what's happening specifically in our institutions in the context of institutions as employers, not only as ourselves as employers, but business industry around us. Who's hiring? Who's coming in? Who is losing jobs? Who's leaving? And so as we look at that, organizational adaptability is a very clear definition that showcases that you must have direction, people to lead it, and the ability to understand and analyze those gaps, to then come together to collaborate and understand what the actual actionable next steps are. Organizational adaptability is also a discipline. It comes from organization theory and strategic management. And in that discipline, that is already a very large basis of knowledge and multiple departmental, so to speak, actions that need to be undertaken in concert and connected and congruent as we go through what is called organizational strategy and strategic change. Organizational adaptability is also comes from multiple disciplines. So itself is an amalgamation of all of these additional disciplines: organizational ecology, evolutionary economics, industrial psychology, organizational psychology, sociology. Many of us that have licensure in licensed clinical social work, master's in social work, continuation studies through to psychology, psychiatry, you have a really good clinical foundation of this discipline. But have we taken that clinical foundation of this discipline and applied it in our own structures of our organization? Those of us that are individuals that are part of the core structure, core team in building teams, identifying roles and positions, staffing support, are we looking at what the psychology and the behavioral economics of our staff look like? How are we teaming? How do we select teams? And for those of us that are having direct interactions with patients, how do we apply the sociological factors of this adaptation? As we change our services, how do we measure, message, and monitor that? And as we are having to reduce services or enhance services or evolve services, have we transitioned that messaging across so that our patients are understanding of what it is, their expectation when they come into the office, when they come into the clinic. Organizational adaptability has really three primary calls to action for when you, quote unquote, utilize this framework. It is to say, is the strategy mapped to the execution? Is what we intended to do what we actually did? And hence all of the good work that we do in coming together in conferences, hearing from our peers regarding case studies, and also continuing to learn about how can we make these tweaks to better improve our patient service, our employee satisfaction, our overall structure and capabilities, capacities, and competencies. It is the relationship between organizations and their environments. We can term environments to be community, to be regulatory, to be our own individual interdependent environments within siloed different cultures within our organizations. And then it is the study of organizations itself, populations and organizations, and then overall the organizational fields that expand. So we talked a lot yesterday during Dr. Dennis Rudnick's, what are our HR professionals doing and how can we all be HR professionals in the context of really outreaching, ensuring that from an individual accountability perspective, we are knowing who we're working with and giving them the opportunity to share their identities and also allowing them a safe space to bring their holistic self. And as we look at that from an organizational adaptability perspective, it's very complex, right? It is difficult to pinpoint any single one thing and make that one thing change throughout to have the maximum impact at the end. It's all of these things together and taking the momentum of all of these things together that will ultimately impact and change that organization. Certainly, this is a very complicated slide, but I wanted to visualize that change and say it starts with one person learning, educating, being self-aware, identifying their own implicit and explicit biases, continuing to have open-mindedness to bring in information, having the patience to sit on that information and only sharing it when it is appropriate in disclosure, and keeping it so that we can connect and collaborate in the support of our three main focuses of bettering patient services, increasing employee satisfaction, and overall creating a stronger community network for mental well-being. I'm not going to go into detail on this framework. Quite frankly, I am not well positioned to speak on this entire framework. It could probably be a whole nother webinar unto itself, and this is a doctoral level study within organizational adaptation, but I wanted to provide that visualization. What I will do next is to invite my panelists this morning to share their perspectives on how all of this complexity interpreted in each of the areas that they'll be representing can actually move forward, as we have over 120 people joining with us today that have different roles, different influences, different leadership focuses, and different authorities within their organization. So in which part and play could we actually collaborate, each have a defined direction and strategic next step to ultimately increase the change management that is both congruent and consistent within our organizations. So I'm going to invite Kelly Meyer, Kelly Lester, and Suzanne Clifford to share their videos. And I'm going to give a quick couple-second sentence intro on each of these phenomenal ladies to give you a little bit more background on themselves, and then also the perspective that they will be bringing to the conversation today regarding organizational adaptability. So first off, Kelly Meyer is the president of Kelly Meyer Training Solutions, and she founded the organization back in 2011, where she has been focused specifically on developing training for law enforcement, corrections, and first responders for 20 years, which has resulted in a measurable reduction of use by force by 70%. Kelly Meyer has been on the Division of Mental Health and Addiction Cultural Competency Enhancement Project for the last 3 years and is guiding our transformation change agency teams as well, which is a group of stakeholders really focused on intentional change within their organizations. Suzanne Clifford is the CEO of Inspiring Transformations, a consulting practice that partners with executive leaders and mental health coalitions to implement transformational change in mental health, substance use, prevention, treatment, and overall health and well-being. And she received the highest honor that the governor can bestow upon a citizen, the Sagamore of the Wabash, for her leadership in those areas. Suzanne has a forthcoming book coming out at the end of this year that is focused on transformational change in healthcare, which is specifically the items that we are discussing throughout this conference. Kelly Lester is the Chief Strategy Officer for Engaging Solutions, and she leads the company's strategic initiatives, business development, marketing, and diversity, equity, and inclusion service line. She has been an equal opportunity activist, a community leader, and an ambassador to local and national populations. Kelly has been named one of 30 young leaders of the future and takes that acknowledgement very seriously in her continuous efforts in working and bridging community economic development with D&I integrated with overall cultural competency of not just doing the work, but how to do the work in a way that is successful for long-term partnerships across collaborations. Ladies, I am humbled for this amazing stalwart of subject matter expertise that is with us today. So welcome, welcome. I'm going to start off the panel with a first question, which is really specific to an announcement that was made yesterday that so much great information was shared by Dr. Merritt, Dr. Carey, and Rachel that I just want to take a moment to breathe that in and seek your perspectives. So yesterday, our leadership shared with us changes in DMHA's organizational structure, leading to better system integration and expansion of services. This is one example of organizational change management based upon our known environmental changes. So there was coupling with FSSA strategy, regulatory, the dollars that came from American Rescue Plan and COVID-19 relief. Those environmental changes significantly impact the ability to structure and restructure how we do our work in the state. So how does yesterday's system-wide announcement really impact our providers? Your perspectives?
Yeah, I'll go ahead and start. Well, if you think about transformational change, and as Sunny mentioned, I've been studying this and working with a co-author on a book on the subject. If you really want to make massive change, you have to change your thinking. And then you can change behavior, and then you get better results. If you just want incremental change, you can change behavior and results. But really, huge, massive change requires thinking changes. So what thinking changes did we hear about yesterday? We heard about going from silos to real integration. We heard about focusing just on treatment to really going early in prevention to treatment to recovery. We heard about, lots of degrees to degrees are still important, and we want those clinical experts, but we also want to embrace and value the lived experience. So how do we look at that differently? And that will require a thinking change on our part. And so for each organization, doing your own environmental assessment and really understanding the data, because I think Rachel shared some scary statistics about people being underserved in different populations, and you need to do your own local data analysis with the information you have and have some data-driven decisions so that you can change your strategic plan and shift your thinking. But data is one way to shift thinking, and I think that will be very helpful.
Suzanne, thank you so much for that. Having led FSSA in the past, I know you've got a lot of institutional knowledge looking at the history of that evolution. And so thank you for just pinpointing exactly the areas of change that are being called out.
Okay, well, what I was suggesting is that we really need to know our numbers. And many times those numbers are identifying what our true gaps are. I like to think about diversity as what you don't have, right? And within the comment that Suzanne made, which I loved, we need to really understand that based upon weighted input. So we learned a lot about that yesterday, pulling teams together that actually can make a difference on that particular policy. And that will then help us. So as we look at incremental change, it will be very important to engage those individuals that actually are closest to the process, to improve that process, to ensure it's inclusive, versus us sitting in a room, 2 or 3 people, or HR folks or D&I folks trying to figure that out on our own. And that's a very intentional decision-making process around what will change, when will it change, versus making missteps.
Kelly Lester, could you expand upon weighted input and give some examples for the providers on call of what does that really mean, and how do you actually action that? What are we doing when we're saying weighted input?
Yeah, absolutely. So ultimately, we may have trouble recruiting early career, or difficulty in better understanding what it takes to develop women differently than men within our organization. And so what you want to do is not have folks that are in the baby boomer era deciding what early career development should look like or how we should recruit, but ultimately going to the source. Similarly, if you look at your development process now, it's probably working okay, but if you cut that by the demographic data and notice that women aren't engaged, or they're falling out, or leaving the organization, off-ramping, you've probably heard of that term, on and off-ramp based upon a woman's career or when she decides to have a baby. Ultimately, by engaging with women that are the target audience, they should have weighted input. So you can use employee resource groups or councils as diverse cross sections, and most of my clients do, but you really want to be sure that whether they're part of a council or a strategy team or just a staff member, that you're engaging them and weighting their input higher than others, given the process we're looking at.
I think it's phenomenal. And just by way of some statistics, we have about 400 folks that continuously participate in this learning collaborative that is the Cultural Competency Enhancement Project. And in each of these, we ask the question of, in your field, how long have you served? And 38% of this 400 plus collaborative that they serve in the field less than 5 years. So there's a tremendous amount of training that's needed to ensure that those that are coming into the field stay in the field and have mentors, have professional development, have intentional organizational training to support what a career in the field really looks like. Kelly Meyer, your thoughts?
I love everything that you're saying, and it's so powerful. And then just coming from that frontline piece of it, it's like, where do we start? And I think the first thing is remembering that we're in the human being business. And so how do we serve our clients best? If we put policies and we put things in place and we say, well, this is for you, well, did it include you throughout? So as we talk about teamwork, we're breaking down these silos, and we are engaging in teamwork. What kind of team building type exercises are we doing within our organizations that help us with staff retention, so people really feel like that they belong and that they're part of a family and they're part of this work? As we ask we learn information, we have all of our good intentions, we do a needs assessment, we have information. What is next? Looking at Kelly and Suzanne both said, look at our gaps. What are our gaps that we need to fill? And if we are identifying those and saying, oh, let's take this breath. Let's see what it is to hand off to someone, what it is to really carry that individual, and take a few case studies and actually follow through to say, do our policies match our service delivery? And as we bring those additional partners and as we're liaising with those additional partners, does something happen? Are we matching their policies? So our thresholds for treatment, are we really sending people at the right place? Have we really had this communication? And it's communication with like folks from the various agencies. So if you have the program level here, let's match it with the program level over here. If we have organizational leadership, let's match it with the organizational leadership, and let's get our frontline folks kind of matched up to say, oh, so people are comfortable talking to each other, so they're not adverse to our change, and they're not scared of change. They're very comfortable with the entire process and those around, and they have a comfort in knowing what that next step is, and they're getting it right as we make some of this change.
Kelly, I love that. Oh, go ahead, Kelly, please.
I was just going to suggest one quick comment I wanted to make is that this is overwhelming. It can be. So how do we demystify, if you will, the confusion around it? And I think it's going to be prioritization. So I love what Kelly was sharing, because we have to look at the patient, if you will, who we're serving as the whole person, which we talked a lot about yesterday, I think. But how do we leverage those touching the process in that weighted input place, those we're serving in that weighted input place? But the other thing is could we actually go back to our staff and say, of all these things, right, what's the top priority? Because that too will help lessen the confusion to say, where should we start? And what are we really wanting to accomplish in year one? And that's a hard thing to do for many organizations, especially because of our hearts and how we want to serve in these roles. But I think it's important that we do so we see a win in terms of progress at the end. And that's really been critical for all of my clients.
Please, Suzanne.
Yeah, I'll jump in too, because I want to give you a couple real life examples. I think kudos goes to Eskenazi Health, because I think they're thinking way outside the box, and they're also recognizing that their team needs self-care skills, especially when we're doing this work. It brings up trauma, it brings up some shame and doubt about what I've done in the past and how I've acted in the past. And so we also have to think about self-care. And Eskenazi Health's done a terrific job working with the Center for Mind-Body Medicine to train lots of leaders and certify lots of leaders within their organization, and then they've gone outside their organization. But within their organization, now they have these groups where each of them are training more and more people in self-care skills. And they recognize that's what their team needed to take the next step. Also, some pretty innovative public safety teams are starting to realize that they have to get much better about education about mental health and really good services. So rather than putting somebody on leave, really keeping them in service, maybe at a desk, but getting the service and the supports that they need from their own mental health, so that they can show up better for the people that they're serving in their community. So those are a couple examples.
Mm-hmm. Well, and so true. And sometimes they're unrealized partners. So working with some folks in Daviess County, where the whole community decided to come together and say, let's train on this together. Let's understand the problems together. Let's identify gaps together. They're doing a fantastic job. But a thing is, when people are in distress, who do they call for help? They call dispatch. They call 911, and where 911 puts these folks. And so they actually made a partnership with peer recovery specialists who are part of a deployment team as well, maybe even ahead of a first responder. I mean, they are a first responder, but it's somebody, it's like, who can help? I just want to take a drink, or I'm hearing who's going to stop me, from taking that drink or taking that hit, who I'm hearing voices, the voices are getting mean, who can help me talk to, and even getting a different type of service that dispatch didn't even, that nobody had really worked them into the equation until they identified the gaps. I think it's finding some of those new unique structure points that will elevate the great work that everyone's doing, but look how it enhances when you bring the partner on board.
That's excellent. I want to just quickly summarize these phenomenally salient points. So design a team with weighted input, identify the gaps, co-produce the solutions, then prioritize which solutions you're going to go after, and then not only check on the project progress, but also the people progress. So what does that self-care look like? I'm going to introduce an audience member question because I think it fits so well. One of our participants asked as a opportunity, and if you all could walk us through this opportunity, so how would you collect data for undocumented groups as a part of organizational adaptability in being inclusive of populations that we do see and provide care for, but we ultimately cannot necessarily track in a directed way? So thoughts on that?
I was impressed with something, I think it was Northwestern hospital medical practice, their whole group, hospital group did, is they did things that they gave you as a client, you're a number, okay? So not even just even following and tracking that number through. So it's tracking the number associated with, so it removes any type of stigmatizing anything because you're just a number. And even in the waiting room, think of this, it's your next up. So if someone of color, for example, seemed to be sitting there an extra longer bit of time and saw what appeared to be more white folks going into to being served from the waiting room, what they did is they even had a board where your number popped up and said who was next and who, you know, and approximately how much time it would be for the next client. And that time changed, you know, based on how long a patient needed to be in there. But you could clearly see that your number was advancing in the order in which your appointment, and even tracking those data that went with that individual went with a number, and that kind of made people feel more equal, but it also gave them an ability to give someone who was undocumented a more confidence in knowing that because their name may look a certain way, or they could be identified a certain way, or whatever, it was just a number, everyone, just a number. So there was equality about that, and it allowed more information to go through with that number.
That's a really interesting logistics process in showcasing the expectation to the patient coming in that all you need to do is get the number. Once you've gotten the number, the care will follow, versus our traditional intake processes, which are insurance information, filling out a form that if I have limited English proficiency, I might not be able to complete. And so that's a very intriguing, kind of goes against the don't treat your patients like a number, but literally the logistics process is you get a number and you get care. Very simplified messaging there. Kelly Lester, you had additional thoughts?
Well, the only add would be it's more of a lagging indicator versus that front end. But one of my clients did stakeholder outreach and engagement for certain groups that we were seeing increase in the community. And the whole objective is like, how do we better serve, right? Documented or undocumented. And so those focus groups, it's one way to do that. So if you're probably not staffed to do that yourself, but if you are, that's a great way to do that. But you can also hire someone out to do that, or leverage studies within, you know, your particular area around what are the needs of that group. It may not get as specific to your particular service, but you can at least look within, you know, the service umbrella of, you know, mental health or a particular addiction, so that we can understand the gaps through focus groups. Then you can try to apply those based upon what you're already seeing. The other thing is just ask your staff, right? So I think we kind of overlook that and just say, you know, what are we seeing? What, again, back to what Suzanne was talking about in terms of gaining input.
I'd also say that a couple other real world examples, Hancock Health and the system of care in Hancock County, which is like 100 different organizations. I mean, they have a very engaged system of care. The hospital brings in lunch, which I think is helpful as well. But they do their community health needs assessment, and all of the members of the system of care hand out the community health needs assessment and actually help people fill it out with their client base. So they work with people that are addressing social determinants of health. They work with the mental health providers and other people. And so they get a much more diverse picture than most hospital community health needs assessments. And so that's just one other way. And from that, they found, hey, we need better navigation. People are having a hard time figuring out how to get into the system. You almost need a PhD just to figure out how to navigate the mental health system, right? And then once you navigate the mental health system, maybe you still have some pretty major social determinants, the health barriers. And they really were able to do a lot more. Even during the pandemic, they got better information for and their report is so much more robust than most community health needs assessments. So that's an example. The other one, and I know you're going to hear from an awesome superintendent of schools, Alicia Johnson, for lunch today for IPS. Ask the school social workers. They really do know what's going on, and they can tell you who's really nervous about getting their kids into care, or the parents nervous about getting into care, what the barriers are, the fear of being in the system and that slowing down the process of gaining citizenship. So they can tell you a lot too.
And you said the thing with the PhD, and the cool part about that is there are dollars out there right now for deploying a paraprofessional workforce. So if there are dollars for peer recovery, there are dollars for community health workers, and I say access those, because when people are sitting with not the PhD and realize you have a very colloquial knowledge, you have subject matter knowledge, plus you understand their problem. Maybe there's even bilingual, pieces there, but a real understanding and a comfort level. So you build that trust, you establish that piece. That goes so much further. And then with that individual collecting our data bits and the follow through for the data bits, we are able to track a little bit more. And additionally, the big in our opening statement yesterday, that trauma-informed workforce, that we are reducing trauma and stress throughout this whole process and identifying some other pieces there. So it just adds to our data collection, adds to our service delivery, and really enhances the whole process.
I love that. Using paraprofessionals, doing focus groups, as Kelly Lester recommended. And, I love this idea of a community needs assessment wrapped as a community block party. We should do more of that. That is phenomenal. Really, hats off to Hancock County Health System for the collaborative for doing that. That's a phenomenal way to engage. Well, ladies, we've talked a lot about organizational adaptability within the organization. Let's take it one evolutionary circle further and talk a little bit about what are the changes towards systemic change. So many organizations coming together. We have now gone from internal strategy and directioning. We know what we're doing. How do we align with what others are doing to pull all of this together for system-wide change? Because we need it and we want it. So how do we do it?
Yeah, well, I think one of the best examples out there is the city of Fishers. If you have not checked out stigmafreefishers.com, and really even that website doesn't do it justice. They're going to update it, but they spend a lot more time doing than updating their website. But the mayor of Fishers years ago now said, hey, we're going to make mental health a priority. This was before mental health was cool. Okay, this was before even we were openly recognizing the opioid crisis that had been going on for a long time. But he made it a priority. He gathered many different people from all over the community together. People with lived experience were very active, and the peers were very active in the process. They really looked at how to do schools differently. Now, I will say that their support systems in the schools are extremely robust, but current funding systems make it hard to do that. So we do have to redesign our systems and our funding so that that can be supported. I will say with schools, parent permission is always a priority, and parents are engaged. And then they really took it to the next level during the pandemic. The city of Fishers is one of the only places in the country that started a new health department during the pandemic. Wow. And I remember the mayor calling me about it, and I said, are you serious? You're really going to pull this off? Well, it ends up that that tiny little new health department delivered more vaccines and COVID tests than almost anywhere else in Indiana. It was one of the top ones in the entire state. And they did so many outreach events, I believe 50 or 70 outreach events. And they went to places where they knew people were not, were underserved and needed to be pulled in, and wanted them to feel like they belonged. So they went to people's apartment and did fun events. You talked about block party. Let's make it fun. They went to neighborhoods and brought testing and vaccinations to the people versus waiting for people to come. And then they kicked off a community health needs assessment, and they're in the process of doing a very, very deep dive with many focus groups so that they could take it to the next level. And the health department in Fishers is now taking on mental health as a key priority. So that's an example of engaging the whole community. And even if your mayor's not totally on board yet, you can still mobilize a community to really make a difference. And their outcomes are showing it: less suicides, less immediate detentions required. So they're really moving upstream into the prevention with that vision that DMHA shared yesterday.
You know, I think it's so poignant about this. We did have the mayor of Fisher, Scott Fadness, and his team on the conference in 2020, and they actually shared their vision of what they were currently in the midst of, and also the direction of what they want to do. And I think in the context of this systemic change and systemic driven focus, it's really who is the organization, which is the organization that is in the best lead strategy role. In this case, when Suzanne shared, it's the city, city, local municipality, city, county councils, et cetera. We need to engage those folks in the understanding of mental health. They are the first folks that need to be supportive of anti-stigma campaigns and supportive of the directions of our CMHCs, OTPs, recovery housing, right? We cannot move forward with those without systemic change and allowances in the zoning and also housing policies, et cetera. The City of Fishers is a wonderful case study and model of how that systemic systems collaboration is changing and supporting adaptation within our communities. Fantastic, Suzanne. Kelly Meyer, Kelly Lester, additional insights?
Yeah, I think too, I think we look at these communities who are very progressive and who are bringing the partners together, and then we have to kind of take a look at ourselves and do a self-check as well and say, you know, when people ask, hey, do you have a policy on this? Yep, we sure do. Here's file ABC with policy, and it checked the box. We've been checking that box for And this is absolutely true. We as part of the transformation project and asking people to go back and look at their agency's policies on various things and say, you know, produce these, let's take a look at the language, and let's take a look at the service delivery. Let's see if it all matches. And one agency was a 100-year-old agency and actually had a 100-year-old policy that's what they were using, that was still in place, and it didn't even list the title of the individual with the job. It listed the individual by name who was in charge. So it was like the director or superintendent at the time. It was the program director's name, and that was of 100 years ago. So yes, you may have your policies, you may be with it, you may be able to check the box, but can we just take a little second look at ourselves and say, are we really living the life and the service delivery that we want to live?
You know, Kelly Meyer, that's so funny that you identified that, and it's you know, that should be in historical archives, right, for the organization. But I have some thoughts regarding that. What is our latest revision of public health policies in the state? What is our latest revision of administrative code in the state? What is the latest revision of overall structural changes from a legislative perspective? I know our leadership team is working very hard, but roles, right? Our leadership cannot advocate and lobby for change on a legislative area. Suzanne can back me up on this. There are rules of what we can and cannot do. And so, well, who is doing that, right? So Kelly Lester, some thoughts?
Yeah, well, first of all, I'm so glad Kelly mentioned this, because we keep going to the policy to tweak it. And when we begin to look at equity and how we embed it, we may have to blow the whole thing up, right? We may have to start over. And that, I know, sounds daunting, but it really, if we're looking at the environmental changes, and I'll just speak to one example and a specific situation with one of my clients. So who we're serving, the complexion of that group has completely changed, but our workforce that's serving them may not have. And it's not about making sure, as we learned yesterday, that, you know, everyone that's serving, you know, I will get that the salesperson that's Black goes to the Black, you know, you don't do that. It's about how do we get everyone culturally competent. But we may need to look at the actual policy and say, it's not serving us anymore. An example of working with Anthem is to Suzanne's point, we talked about lived experiences, but we haven't aligned a policy to address it. And so what I would question and suggest, and what we did with our Anthem client with Anthem, is we looked at the roles. Is it dated, right? Do we still need all of those things? What else is needed? And the way I would describe it is we have to expand what we see as good, or our profile of success, in order to serve based upon the environmental changes. And that changed everything. So if a person that understands the complexity of the fear that African Americans might have when it comes to healthcare of any kind, then the way that they actually engage is different, and it can make a difference, even if we're doing surveys, right? Or just saying, hey, we're going to have the community health worker ask this question, but I'm not answering the question if I don't feel trust. So I know I'm putting a lot in that conversation, but I do think it starts with our policies. Are they expansive? Have we expanded the profile of success? Then when we put people in those roles, regardless of their backgrounds, do we really listen so that we can get to the real need and then advocate, right?
Well, and the thing is, like with that, we have our policies that are written, and we have our laws that are written, and we have people who have to write descriptors based picking from our policy words sometimes to write on about an individual. And we have to, like, think of our police officers who have to extract from law to write about an individual. And if the law says that they're retarded, that it's retardation, no one's going to get that diagnosis. They can't use the language that's cited in the law. So they have to pick and choose the language that's in the law to even write up certain ways that they can get folks to treatment, because our language and our laws are so outdated that has to be changed, has to be brought to a modern day thing, because to get those descriptors in that refer back to law, they have to be relevant.
Yeah, so you asked who should do it. The state can do some things, and so it's really important that the state does as much as they're allowed to do. And then I think advocacy organizations and professional organizations, the Indiana Council, Mental Health America, NAMI, American Foundation for Suicide Prevention. We do have some great organizations, Key Consumer. There are many other organizations out there that we need to have coalitions, and we do need a better presence at the legislature. There's no doubt about that. I do have a comment too about how do we have to start thinking differently. I talked about thinking changes, right? And Kelly Lester mentioned how, maybe our workforce doesn't represent the diversity that's within the community. How do we make that happen? And I do think we need to think differently about that. How do we engage schools? And I'll give you an example of that. Working with Indianapolis Public Schools, I work with a nonprofit called Give an Hour, and the Women's Fund's part of that. The Marion County Public Health Department's part of that. Drug-Free Marion County's part of that. And we got some Department of Education support, and put together a program where we go into the schools and we work with students once a week in a fun way and teach them about the signs, teach them about mental health, teach them about healthy habits of emotional well-being, talk about the actual risks of marijuana use in children and alcohol in children, and get them engaged so that they have language to go back. And many of those children are going back to families that have a lot of stigma or concern about mental health and substance use disorder treatment. But and we're also doing some family events. One innovative thing that I think we should talk about too is volunteers. I was able to recruit all kinds of diverse female role models that were executive level. So most of them were like CEOs, the former CEO of Community Hospital East, and an executive at Eskenazi Health, and all these really amazing people. And they were able to serve as role models and go into the schools and kind of change the culture with the children, and partner with the parents as positive role models. And now we can really encourage kids. Some of these kids have lived experience having to deal with social determinants of health and taking care of their siblings while their parents have 3 jobs. They're in a terrific position to become social workers or other people in the field. So how do we work with schools and start to engage youth so that they want to be part of our mental health team? And I think that's really, really important, and we need to do more of that.
And not just
I think we
recruiting,
also need to look at our licensing practices and overall from a systemic thing for Indiana. We are hearing from the workforce in a big way. So if it's advocacy from the workforce to the state, or how the state looks at licensing, Indiana's notoriously slow. So if folks are, and we need folks to be hired in our, but if they get a job someplace else and they haven't received their licensure in Indiana, we're not going to get those folks. And we're missing out on a good pool of people that we need to say, hey, what does that process look like, and how can we make some improvements and see who are we missing? What are the types of professionals that we need to license, and what does that look like in a time frame that's acceptable, so we can get people in those jobs to fill those gaps?
So not just recruiting for tomorrow, but really looking at youth voice of today, looking and hearing from our professionals that are coming in from other states, right? We've had a huge in-migration into Indiana from both coasts during the pandemic, because people are tired of living in cities, and remote work has completely changed the opportunity for where you work versus where you live. Just a quick summary of our conversation. So, we have in systemic change, our organizations have to identify what role they are playing in collaboration with others. And we can't always look to one specific entity to do it all. We need to understand that is a shared action and shared responsibility. So we have organizations that have the role of authority, have the role of advocate, have the role of activating, and then, not so popular, but very important, the role of audit, which will transition us to our next and final question for today. What a phenomenal conversation. So in context of audit, training. We have so much training, ad nauseum training. What is really the way to drive effective training in our organizations, and what role does training really play in systemic change?
I know Kelly probably wants to take that first. Did you want to come?
I do. I feel like I jumped a little too much before. Go right ahead, but
Okay, I'll comment. So I think two things are coming to mind for me relative to what we've seen in our work. And no one is sitting in training long anymore. So a bite-sized learning. And then I'm not a L&D specialist, learning and development specialist, but most learning and development folks will tell you people aren't really learning as much in the class. There's only a smaller percentage. So or they have a wow experience, but the key is measurement and application. So bite-sized learning, and then measurement and application. So how were you able to apply this on the job? So we've got to begin to design our training based upon what the appetite and time is, right, for people. So I've seen a ton of clients go to, I used to do a whole day of diversity and inclusion training. Now I barely get 90 minutes. That's been the average. At some government institutions will allow me to do 2 to 4 hours or a 4-part series. So we've just adapted. Virtual learning, bite-sized learning, e-learning, making sure you can do it on your phone, but doing it with expectations for self-directed application. One of my clients, I love that they have what they call a playlist. So it's almost like a music list, and they put it on their website based on the particular learner. So leaders had a playlist, such and such roles had a playlist, and I love that because it's pretty much how we live now. Right? And so I think that's the key point I want to make, is we have to lean into how people live and learn today. And then our measures have to be connected to what is it that we're trying to change. Your immediate is attendance. We do that all the time. The second we often do is what was the experience like, and what types of training would you like more topics on? So you could put that in your immediate surveys, but you have to look at post the training, how were you able to apply it to the job? And then lagging indicator would be your engagement surveys. Is it a more inclusive environment? Things like that. People, do they know how your policies around D&I is your policies are promoting D&I, right? So it's in the questions. Sometimes the devil's in the details around the types of questions we ask.
I think people put together some really good trainings. They're really good things, whether we're doing them virtually or live. We've got to still come up with some sort of team engagement. So even if we're doing virtual training, you please have some team building or something you're giving to your employees back at the site. But the big thing is with training, especially since we've gone to a virtual environment, is stop taking your employees' time and not giving something back. It is just, you know, here, we're going to do this through lunch, you know, sit and eat your lunch. Well, I didn't have time to make it because I was working up until lunch hour. Now you're making me sit through lunch. You're not feeding me lunch. You're not giving me anything. I have to sit here and listen. Can I even, you know, and if I'm working at a facility, because most of people still have patients and they're there. And when the 20 to 30% of staff that we have, that we're retaining, that we're keeping, that we're not turning over, ask for something, listen. And so if someone asks for something, even if you think it's way out there, that says, you know what, all right, I'll work through my lunch hour, I'll work through my breaks, I'll do all this for 4 days, I'll see patients, you know, straight through, but on that 5th day, will you just let me be at home? Will you let me get all my paperwork done? Will you let me have no patients or no whatever? If they ask something like that, actually listen and look at your data and see what's happening. Or if they ask for some other little thing, these are the people you're keeping. Let's make them happy. And if they say, I need more training on this, or I need more supervisory input on this, or just listen. That's what they need. That's the feeder they need. You're probably training to the skill sets. You're probably doing that. And everyone has their own ism on how that is. But don't forget to stop taking from your employees to do training. Give them something as you train.
Yeah, I see training as an employee engagement and retention tool. And so if they're not loving the training, then you're doing it wrong. And if they don't feel closer to their peers after and more belonging is so key. It's important for the people you serve, but it's also important for your teams. If they're not fired up and excited and see how they fit into the vision and see how they're making a difference in this world and how they are really promoting recovery or preventing mental illness and substance use disorder, or really improving the lives of the people that they're working with, then it's not right. So if they don't absolutely love it, then you're missing an opportunity. This is one of your best retention tools. And it may be that you want to use endorsements for certain evidence-based guidelines. Find out what they really care about, maybe certifications. So get innovative about what they care about and what you need to get done and how those two connect.
Mm-hmm. Suzanne Clifford, Kelly Lester, Kelly Meyer, our stalwarts of systemic change and our gurus of organizational adaptability. Thank you, ladies, for your time and very poignant toolkits, actions, and points of note this morning. For everyone that's attended this excellent conversation, there's more learning opportunities on the Networking Cafe with a very short but very simplified 2-minute definition from Deloitte on organizational adaptability, and then also an excellent TED Talk by Jennifer Jones focused on an actual step-by-step how you as an individual through a mathematical equation can participate in organizational adaptability. Again, I won't spoil it for you. I won't ruin the ending, but please take a look in the Networking Cafe under Learning Topics. Ladies, it was a pleasure. Thank you so much. We'll close the session. Take care, everyone.